Mirror. Sweet. Okay. Is it running? All right. Okie doke. It looks like it's ready to be set up, and got the wrong title on it though, but that's no big deal. All right. So we are on episode 6 of NPTE Night School. I know that it says, I don't know if you guys can see it, but on my end it says episode 5, but that's my bad. So we're on episode 6. Last week there were some inquiries to go over the endocrine system and pharmacology, also to go over non-systems and gait analysis. So I just picked 2 of those. So tonight we're going to go over the endocrine system and pharmacology. Next week we'll go over gait analysis and we'll do some more non-systems. But I think that it's probably most useful, and maybe I'm wrong about this, but I think it's probably most useful if we just stick to 1 or 2 topics and try to hammer those really hard. It's my favorite day of the week. Thanks, buddy. What tips do you have for our January test takers at this point? Well, user, remind me, yours is like the 26th or 27th, right? Like you're not one of the PTAs that's taking it this week, correct? If you guys are taking it this week, I would say, like if you're some of the PTAs that are taking it this week, I would say if you're taking it on the 7th, do not study at all on the 6th. Same thing for you guys taking it on, like the PTs taking it later this month. I did not study at all the day before. So what did I do? I think I played PlayStation basically all day and read just for fun. If you guys are doing well on your practice tests and you're consistently passing, then I would say just play cleanup on the little bit of stuff that you still have left. I would keep drilling. I think by this point in my studying, when I had less than a month left, I was pretty much just running through the stuff that I knew wasn't going to commit to long-term memory. So like modalities, specifically the iontophoresis medications, which was stupid, but I just had to have a way of keeping it in my brain long enough. ADA requirements, just that kind of like rote memorization stuff that you're just sort of like using the cram style of just running through. But by this point, I had been studying for 16 weeks, or sorry, at this point, I had already been studying for 12 weeks and I was getting gassed. So I basically just kept taking practice tests, and because I still had some for the last month, I was taking like 1 a week and I would go over that stuff just to keep it fresh in my mind. But by this time during my studying, I was not studying 8 hours a day. I don't even think I was studying like 6 hours a day. And there was a point where I was like maybe studying 1 to 2 hours a day because I was just so burned out on studying. And I did great on my tests. I did fine. So as long as you're keeping all the stuff you know in your brain, then at this point, if you're scoring above passing consistently, I would say just play cleanup. If you haven't scored above passing, or you've only scored above passing a couple of times on like several tests, I would say you guys still need to be jamming pretty hard in a study routine. Um, like if you're borderline, like landing between 590 and 610, I would say you'd need to be really identifying those weak points at this point that are going to give you the biggest bang for your buck. So if you're consistently scoring below 600 on your, sorry, I got distracted by an email. If you are scoring below 600 consistently on any of the major content areas, meaning MSK, cardiopulm, or neuro, you need to be hitting that stuff hard because that's going to be the majority of your test. It's the majority of every NPTE, right? If you are scoring below on the non-systems or other systems stuff, I would start studying that. If you're consistently getting above 600, especially well above 600 on your main three, but you're scoring really low in the other areas, I would just start hitting the other areas hard and study the big three sparingly just to maintain your knowledge, right? But figure out what your weakest point is, especially if it's scoring below passing, and just hit it hard for at least 1 week, and then retest and see where you're at. Right? See if you've brought your scores up at all. That's what I would say. You guys are reading the question. Sorry, I haven't even gotten to the question yet. But user, that's what I would say for now. It kind of depends on where you're at in terms of how your tests, your practice tests are going. Because that's going to dictate if you can take this last 3 weeks easy, or if you need to be like really cranking and burning the candle at both ends. But either way, I would not study the day before your test. If you guys have been studying for weeks and weeks and weeks, and you don't have it by the 26th, then you're not going to have it by the 27th. Which I'm not trying to be discouraging in that regard, but I think it's realistic, and it also just gives you some time to relax before you go into the biggest test of your life, right? Okay, let's go over question 2. So I posted question 1 yesterday, so we're going to start with question 2. There's another question later on that I'll skip past because I posted it yesterday as well. So a patient with uncontrolled type 2 diabetes is most likely to demonstrate which finding? A, bradycardia, B, decreased risk of infection, C, increased insulin sensitivity, or D, delayed wound healing. Many of you have answered. I encourage you guys to answer because the more you interact in studying, like with this, the more it's going to stick in your brain, whether you get it right or you get it wrong, because we're going to go over the answers. I say this every week, and many of you who are repeat viewers probably get tired of me saying this every week, but the more you interact with material, the more it's going to stick in your brain, and you're going to create the neural connections that help you codify that information during rest time, your long-term rest. Sorry. Okay. Oh, heavens. Okay, cool. So many of you are saying D. Someone says, why D? So let's go. D is the correct answer. So D, you've got delayed wound healing because in uncontrolled diabetes, you have poor glycemic control, which is going to impair your healing. So the more that you have out of whack blood sugars, the more damage ultimately that's going to do to your arteries and your veins. So your circulation starts to get more impaired. That's why people tend to develop more neuropathies, because the blood flow is impaired to those areas. That's why they start to develop poor vision or blindness, because they have poor circulation. And user easy. I don't care if she comes in. It's not gonna bother me if people just want to hang out in here. That was funny. But basically, when people have poor glycemic control, especially chronically, they're going to get impaired circulation. And if you have impaired circulation, you're obviously going to have impaired wound healing. The reason it's not bradycardia is because diabetes tends to lead to abnormalities of heart, right, and not tend to cause resting bradycardia. C, increased insulin sensitivity. Type 2 diabetes is defined by insulin resistance, not insulin sensitivity. And so it's the exact opposite, in fact. And then decreased risk of infection. Diabetes increases infection risk due to impaired immune function. And so, so when you have long-term poor glycemic control, you're going to end up having worsening immune function and worsening circulatory system. So if you have poor circulation, then you're going to have poor wound healing. So let's move on to number 3. The first 3 answers are up here. I'll have to scroll down for D, but a patient with hyperthyroidism would most likely present with which combination of findings? A, weight gain, bradycardia, cold intolerance. B, weight loss, heat intolerance, tachycardia. C, fatigue, hypotension, and hyperpigmentation. Or D, proximal muscle weakness, moon phase, and striae. Yeah, take your time, answer the question. We'll get to it here in just a bit. Let me scroll back up to the question in case you guys want to see the stem again. A patient with hyperthyroidism would most likely present with which combination of findings? A, weight gain, bradycardia, cold intolerance. B, weight loss, heat intolerance, tachycardia. C, fatigue, hypotension, and hyperpigmentation. Or D, proximal muscle weakness, moon face, and striae. If you know your systemic, like endocrine conditions, you can probably look at each one of these and tell me what these are key symptoms of. And so let me just throw the question out there. What is A describing? What systemic condition is A describing? D is Cushing's. You're absolutely right. See if anyone can tell me what symptoms A is describing. C's Addison's. Yep. Austin, nice. Hypothyroidism. So B is the correct answer. Weight loss, heat intolerance, and tachycardia is classic hyperthyroidism presentation. A, weight gain, bradycardia, and cold intolerance are signs of hypothyroidism. C, fatigue, hypotension, hyperpigmentation is indicative of Addison's disease. And if you see moon face, I didn't even write the other one, proximal muscle weakness. Moon face and striae, though, are hallmark signs of Cushing's disease. Proximal muscle weakness as well. You'll start getting out in the community after you get done with your test, and you will start seeing people with these classic signs, and especially if they have really small glutes, but they're bigger in their upper body, just like overweight, and you're going to be like, I bet you that person has Cushing's. What up, Trent? It's good to have you, man. You changed your name, I think. You changed your name on TikTok. All right, let's move on to number 4. During gait training, a patient with diabetes complains of numbness and burning in both feet. This is most consistent with A, peripheral neuropathy, B, autonomic neuropathy, C, Charcot-arthropathy, or D, peripheral arterial disease. Hey, congrats, man. Now you can just focus on taking your boards and getting that in the rearview mirror so you can just start practicing. Let me read this again. During gait training, a patient with diabetes complains of numbness and burning in both feet. This is most consistent with A, peripheral neuropathy, B, autonomic neuropathy, C, Charcot-arthropathy, or D, peripheral arterial disease. Give you guys a few more seconds to answer. All right, many of you have hit the nail right on the head with peripheral neuropathy. Let's talk about these other ones, though, so that way you get an idea of what that would look like if you get asked about it. So A, peripheral neuropathy. This is one thing I didn't include in the stem of the question, but even so, you guys didn't seem to get thrown off by this at all. But if they're describing a stocking glove sensory pattern, sensory loss pattern, peripheral neuropathy, right? That should give it away, especially if they're talking about diabetes. So, autonomic neuropathy would affect blood pressure, heart rate, sweating. It would not result in sensory pain. Okay, Charcot-arthropathy involves joint destruction and deformity, so that would be more like musculoskeletal type pain, not neurogenic type pain. And then peripheral arterial disease is going to cause claudication pain with activity, right? So not numbness and burning at rest, but worsening claudication pain as they get up and move, right? Tell me, pop quiz. I didn't even put this on. How do you know the difference, or what would you do clinically as a test to diagnose vascular claudication versus neurogenic claudication? Go. There's a very easy answer to this. 5-minute walk test, absolutely right. And what would you see? What would be your positive indication, Reb? If you're doing a 5-minute walk test, pain, okay, so more specifically, you're going to have them walk on a treadmill, right? And after 5 minutes of walking, you're going to incline the treadmill. That's going to put them in relative lumbar flexion. If their pain decreases as they walk on an incline, pain on an incline, right? If their pain decreases as they're walking on an incline, it's more likely to be neurogenic claudication. If it doesn't change at all, vascular claudication. Shopping cart sign, absolutely. You're right. All right, let's move on to question number 5. Which finding is most concerning in a patient with long-standing diabetes? A1C of 6.8%, decreased ankle reflexes, non-healing plantar ulcer, or mild post-exercise fatigue? Give you guys some time. But many of you are submitting your answers already. Wait, never mind C. That's okay. You can change your answers up until you submit that whole section of your test. So, okay, let's go ahead and go over it, guys. So, which finding is most concerning in a patient with long-standing diabetes? The answer is C, non-healing plantar ulcer. This would be a limb-threatening complication. If it's not healing and it's not being tended to effectively by wound care, then this can lead to a loss of a limb. So chronically speaking, in a person with long-standing diabetes, an A1C of 6.8 is actually an acceptable glycemic range for many patients. Decreased ankle reflexes, this would not be a big concern, right? Many of our long-standing patients, or patients with long-standing diabetes, that is, especially if they've developed neuropathy, they probably are going to have some of those lower motor neuron signs and symptoms. If it's not immediately limb-threatening, while it's not reversible, you can manage it in a way that it doesn't worsen, or at least doesn't lead to limb loss. And then D, mild post-exercise fatigue. That's pretty non-specific. That's not specific whatsoever to diabetes in general, but it's also pretty normal, especially if they're lethargic relatively. Then mild post-exercise fatigue is going to be pretty common. So not a concern there at all. I would say this, and this is one thing that my buddy says. So user said something. You definitely want to be careful about changing your answers, right? Because you don't want to change your answer out of the right answer. So if you have selected, here's what I would say. Once I selected an answer, the only reason I was changing that answer is if I could give a good reason why the other answer I was looking at was more right. Okay, that's the only reason. I thought greater than 6.5 was considered diabetic. Yes, you're absolutely right, Trent. But we already know they have diabetes, right? So they've already been diagnosed. So it wouldn't be uncommon for that A1C to be above 6.5, right? The STEM talks about how this is a patient with long-standing diabetes. So they've already been diagnosed. But they're still in that diabetic range. But 6.8 is actually going to be generally pretty acceptable if it's a person that's trying to keep their A1C under control. If we were getting above 7, that would be much more concerning. But you're right, in a person that hasn't been diagnosed with diabetes, 6.5 would be kind of that range where they're likely going to get that diagnosis of diabetes. I don't remember what I was saying. Oh, the only reason you should change your answer is if you can talk yourself into a better answer and you can justify it. I only changed 2 when I took both PEDS and passed both, increasing almost 50 points. That's awesome, Austin. I'm really glad to hear that. Something that has helped me avoid changing to the wrong answer is realizing if I'm changing it, I can't see the rest of that. Oh, to an if statement. Yeah, that I made up. Good. Can I see the question again? Sorry. Yeah, Tanya. The question is, which finding is most concerning in a patient with long-standing diabetes? And a development since last week, because I figured this out, I know how. Hey, my wife just joined. What's up, Desiree? I figured out how to get access to these lives after they've ended, and I will be uploading all of my lives onto my YouTube channel, which is linked on my TikTok profile. So if you ever miss a Sunday night and you want to make up for that, It should, by the next day, so by tomorrow, I will try to have this posted. So the reason that this is concerning is it's a non-healing plantar ulcer. They likely will have delayed wound healing, but if a wound isn't healing at all, it's not progressing in a positive direction, then that can be concerning because obviously that can be a risk of like a higher risk of infection, higher risk of tissue necrosis, right? And so that needs to be managed pretty quickly. If you have a wound that's non-healing, that could ultimately lead to limb loss. And limb loss is, yeah, of course, Tanya. So you're right. They will, I mean, it's expected that they'll have delayed wound healing, but they should still be, I mean, ultimately, our hope is that they'll continue to move in a positive direction. Anyway, all of that, I was just saying, like, I'm going to start posting my lives on YouTube the next day after I've done them. So if you ever miss a Sunday night, I'll have it on my YouTube channel later. And that's basically all I post on YouTube. I don't really like make content for YouTube. I just will post my lives. So you guys have a way of seeing them afterwards. Okay, number 6. A patient with Addison's disease is most likely to demonstrate which vital sign response to exercise? A, hypertension, B, exaggerated tachycardia, C, blunted heart rate response, or D, elevated blood glucose? Okay, I've got 3 responses so far out of 82 people on the live, so I'm gonna wait, give you guys some time to think. Try to answer without looking at everyone else's answers. If you have to swipe out of the comments, so that way, it's just because I don't want anyone else's answers to influence yours, because that wouldn't be realistic on test day, right? You don't get to see anyone else's answers. So, okay, getting a lot of answers. Good. I'm glad you guys are. And we got a mixture of answers. So that means I wrote a good question, not an easy one. Good. Okay. Give you guys a little bit longer, and then I'm going to jump into the answer choices and why the right one is right and why the wrong one is wrong. Okay, scrolling down. All right. C, blunted heart rate response is the correct answer. So in Addison's disease, you have inadequate cortisol release, right, or production. And so you're going to get a poor stress response. During exercise, we get more of a sympathetic response of our nervous system. So we expect normally with the right amounts of cortisol in our bodies for that to increase sympathetic response. So blood pressure should go up, heart rate should go up, respiration rate should go up, right? We get vaso constriction, right? That's why our blood pressure goes up. But in Addison's disease, we have inadequate cortisol, so we're going to get a poor stress response or poor exercise response. So we'd expect a blunted heart rate response in exercise. Few got it right. Good. So hypertension, just remember, Addison's is going to be more likely to cause hypotension because of the decreased sympathetic response. Exaggerated tachycardia, body lacks cortisol, so you have poor stress response, so it shouldn't be an exaggerated tachycardia. And elevated blood glucose, Addison's disease is not associated with hyperglycemia. It's associated with hypoglycemia, right? So I misread the question. That's okay. Just anytime that happens to you guys, especially if that's happening to you in your tests, like your practice tests, just make a note of that as you go through as you go over the answers, because if you are a person that is not getting stuff wrong because you didn't know the information or you didn't know the content, but you're just missing because you misread an answer choice or the stem, then just make sure that you practice reading more slowly or rereading, so that way you know that you read the same thing every time you went over it. Okay? All right, next, number 7. A patient with Cushing's disease is at greatest risk for A, hypoglycemia, B, osteoporosis, C, bradycardia, or D, dehydration. Excuse me. Give you guys some time. Good. guys are answering. So one thing that I'll update you guys on in regards to my realm is I went to school with a guy who is now working in Chicago. So we went to school here in Arkansas, and he got hired at this clinic that does vestibular and orthopedics. And his boss runs a CEU company called Evidence CEU. And every year they put on a vestibular symposium in Chicago. And my buddy, Roldan, and his boss have reached out to me to ask about my interest in teaching CEU courses. And so I will go to that vestibular symposium and I'll meet up with them formally and then get an idea of what it would look like if I was going to work for their CEU company. So maybe someday when you guys are working, if any of you are vestibular nerds like me, I'll get to teach you a continuing education course, which would be super fun. So, all right, many of you have answered, and I've just talked to fill the space so that way I don't feel awkward just standing here. But the answer is B, osteoporosis. It's the same reason that chronic use of corticosteroids can cause osteoporosis, that cortisol encourages bone loss. It's trying to make sure that you have adequate calcium in your blood because cortisol tends to lead to, it's an increased, it itself is an increased stress response. We will take CEUs from you. Okay, cool. I'd be glad to see you there, user. Of course, you'll have to come up to me and be like, hey, I'm user 154327889. You've never seen a picture of me or known my real name, which is fine. You can anonymize yourself on TikTok all you want. But if you ever come meet me in person, you have to tell me that you're a user, lots of numbers behind your name. So cortisol is going to encourage the uptake of calcium from your bones into your blood. And so you're going to be more at risk of osteoporosis. Hypoglycemia, so cortisol is going to tend to lead to hyperglycemia for the exact same reason. Increased stress response in your body, so it's in that fight or flight mode, and it's going to try to harvest as much energy from your body as possible to get you through that stress response. Bradycardia, not a classic feature of Cushing's. In fact, it's more unlikely for that stress response reason. And then dehydration. Cortisol promotes fluid retention, not dehydration. So, absolutely. Okay. Number 8, which lab value best indicates long-term glucose control? A, fasting blood glucose. B, oral glucose tolerance test. C, A1C, that's hemoglobin A1C. Or D, random blood glucose. Which lab value best indicates long-term glucose control? Okay, give you guys a little bit more time. Is anyone interested in vestibular rehab? I know that we don't go over it a lot in PT school. I don't know how much you guys get in PTA school, but even in PT school, we basically prepare for posterior canal BPPV and making sure we know when to send people to the hospital because because they've got vertical nystagmus. That's pretty much it. So if you want to be a vestibular therapist or you want to be a good vestibular therapist, usually it takes post-doctoral education. Me and a class in PTA. Yeah, I am fine. I find Vistib pretty interesting. Cool, Luis. Hey, awesome. It's also awesome to see you on here because I just messaged you on your comment on my video today. No, dude, Vistib is super interesting. And the other thing I really care about is I just totally lost my train of thought because I was reading comments. The thing I love so much about Vistib is that it's complicated, and even when you've got post-doctoral education on it, what you see in the real world is freaking challenging. And so that's what's nice about it, is that if you get good at it, people want to come see you for it. And it's always going to make you think. It's going to make you really have to use your brain. Okay, let's go over question 8 because some of you are asking questions about it. So the answer is C, because A1C is going to reflect the past 3 months of your glucose control, right? So this is asking, the stem of the question says, which lab values the best indicates long-term glucose control? And 3 months is the longest term out of any other thing, or any other answer choice. So fasting glucose is going to reflect a single point in time, right? It's not going to reflect trends, although we know that people who have elevated levels of fasting blood glucose do tend to they need to be screened or tested for diabetes, right? Because that's uncommon, right? Or it's abnormal, atypical, I should say. But it's still just looking at one single point in time, right? The oral glucose tolerance test is a diagnostic tool. It's not for long-term monitoring. And then random glucose is highly variable and situational. So the answer there is A1C. Let's go on to number 9. What about, let me ask real quick, inpatient rehab? I just joined. Are these nursing questions? No. Sorry. These are PT and PTA. So preparing people for their NPTE, whether they're a PTA or they're a PT. A patient with diabetic autonomic neuropathy is most likely to exhibit A, postural hypertension. B, increased sweating. C, bradycardia with exercise. Or D, increased exercise tolerance. I think I wrote something wrong in my answer choices here. Hold on one sec. You guys are gonna know as soon as I take my hand away. Okay. Okay. Let me let me try that again. A patient with diabetic autonomic neuropathy is most likely to exhibit A, postural hypotension, B, increased sweating, C, bradycardia with exercise, or D, increased exercise tolerance. Sorry. Sorry, I was writing these really fast, trying to type with my 93 words per minute. Never mind A. I'm sorry. So we'll just go over it since I messed that one up. So the answer is A, postural hypotension. So if there's autonomic involvement, you expect orthostatic hypotension. The reason being, in autonomic neuropathy, we're talking about basically declining integrity of the nerves, right? And so we wouldn't expect them to be excessively working, right? Because that would mean that they're like that you're getting excessive impulses sent through your autonomic nerves, right? Which would then cause something like hypertension or tachycardia or something like that. But in diabetes in particular, if they have an autonomic neuropathy, we're talking about the degeneration of peripheral nerves. And so if they're degenerating, they're not functioning to the level where they can cause hypertension or tachycardia excessively, like at rest, for instance. Okay, so autonomic involvement would cause hypotensive issues, particularly orthostasis. Increased sweating, autonomic neuropathy often causes decreased or absent sweating for everything that I just said. Bradycardia with exercise, autonomic neuropathy causes inappropriate heart responses, often fixed or delayed. And then D, increased exercise tolerance. Exercise tolerance is typically reduced. Does that make sense? Yes, no, maybe so. Move on to number 10, unless someone has a question about that one. Okay. The patient with, can you hit more on the heart rate response? Yeah. So you wouldn't, like, you might expect bradycardia at rest, but because your exercise response is still requiring, like, you're still getting the signals from your muscle, like, hey, we're using a lot of oxygen, we're using a lot of nutrients in the blood, which is then going to be like the primary signaler to your heart that it needs to increase and that your blood pressure needs to increase to still get get blood to the parts of the body that are working. So you might have delayed response because if, like, let's say you have like uh, decreased, I'm sorry, I totally lost my verbiage that I was using. If you have deteriorating nerves, like peripheral nerves, then you might get like those are like you're putting signals in that are saying like, hey, we don't need, or they're not putting in signals that's saying like, hey, we need to increase your heart rate or increase your blood pressure, things like that. But ultimately, you're going to have secondary factors kick in that tell your brain that your heart rate needs to increase, right? And so, in particular, you're decreasing oxygen content in your blood as you're breathing heavier when you're exercising, right? And so that's going to trigger to your brain, I need to breathe faster, I need my heart to beat more, and I need my blood pressure to go up. So you may have a delayed response, but I wouldn't expect you to have decreasing heart rate as you continue to exercise with autonomic neuropathy. Did that make sense, Trent? I know I kind of breezed through that really quickly, but hopefully that makes a little bit more sense. When you're at rest, you can have bradycardia with autonomic neuropathy, but once you get up and start moving, there's secondary signalers to your brain that tell your brain that the autonomic nervous system needs to kick in a little harder. Okay, a patient with newly diagnosed type 2 diabetes asks about exercise. Which recommendation is most appropriate? A, exercise only after meals. B, avoid resistance training. C, limit exercise to less than 10 minutes. Or D, monitor blood glucose before and after exercise. How many questions do I have for you today? I've got 9 more after this one. So let me go through the stem one more time. A patient with newly diagnosed type 2 diabetes asks about exercise. Which recommendation is most appropriate? A, exercise only after meals. B, avoid resistance training. C, limit exercise to less than 10 minutes. Or D, monitor blood glucose before and after exercise. And let me just put in a shameless plug. If you guys enjoy what I do on Sunday nights, if you find this stuff helpful, don't be afraid to like and share my live. Like and share the videos that I make throughout the week. I've been slow in posting stuff recently just because we've been in the holidays, but I'm trying to increase my content throughout the week now that we're through the holidays and I have less stuff keeping me busy. So shameless plug, I really like doing this. I would like to be able to build up my following so that way I have more and more support in being able to do this stuff. I shared my classmate, he's watching tonight too. Cool, thanks dude. Or you can just do word of mouth. Tell people what my handle is on TikTok and they can look up my videos, and if they like it, then they can follow me and watch my lives and all that stuff. But really, I just want to make sure that long term I can continue to do this sort of stuff because I like being a resource, especially a free resource for students. I remember when I was a student, it would have been nice to have something like Kyle Rice's like NPTE question of the week or whatever, question of the day. I don't remember how often he does it, but that's just a free podcast where he goes over NPTE questions. It's like one per episode though. So that free stuff is nice, right? Because then we don't have to spend borrowed money on resources for making us successful in the NPTE, which is frustrating to me that you have to spend borrowed money that is then increasing, the interest is constantly increasing. Yes, I have to thank Solis for letting me know about your live. I truly appreciate it. Yeah, of course, dude. Yeah. Oh, get this. We'll go over this in a second. The answer was D. A lot of you were right. So before I graduated from PT school, I got an email from my school that was like talking about the week of giving or whatever, and like asking me to be a donor to donate money that they were going to use for like, probably funding scholarships realistically. But they sent me that email while I was still in school, and like it was my last semester or whatever, and I was so annoyed by that. So I emailed back and I said, yeah, I haven't even graduated and I haven't passed my boards, so I'm unable to make money. So any money I donate to you right now is stuff I borrowed from the government, and it seems irresponsible to me to give you money that I borrowed that's accruing interest, and then ultimately I'm gonna have to pay off way more. And then I never got a response back, but a lot of my friends were like, that was pretty risky, Austin. You haven't even graduated yet, and you were talking trash to the people that control your life. Okay, exercise only after meals. That's not required, and it actually may increase hypoglycemia risk depending on the medications. So, for instance, metformin, one thing about metformin is that um, a side effect is it can cause like a brief crash after of your blood sugar after you've eaten. And so if they exercise right after they eat and they're on metformin, then it can cause them to have a pretty substantial hypoglycemic event that sometimes it's not simple to solve by just like eating 15 grams of sugar, right? And so that could actually give them an even greater hypoglycemia risk. That's kind of a nuanced answer. I wouldn't expect anyone necessarily to know that unless you just happen to know a lot about metformin because someone in your life has diabetes and takes metformin. Avoid resistance training. Resistance training is actually strongly recommended. Resistance training is going to help load your bones. It's going to help increase blood flow to major areas of your body. And it's going to help build up and maintain the integrity of your muscle tissues. And then limit exercise for less than 10 minutes. That's pretty conservative and it's not supported whatsoever. They're not really going to get good conditioning if they're exercising for less than 10 minutes at a time. A patient taking, this is the pharmacology section we're jumping into now, guys. A patient taking beta blockers begins aerobic exercise. Which response should the PT expect? A, increased heart rate response. B, increased oxygen consumption. C, increased blood pressure. Or D, blunted heart rate response. You guys keep on answering. I'm just looking through, see if I missed anything. Nice. Okay. All right, I'll read through it one more time. A patient taking beta blockers begins aerobic exercise. Which response should the PT expect? A, increased heart rate response. B, increased oxygen consumption. C, increased blood pressure. Or D, blunted heart rate response. And as you guys are answering, I'm realizing that I worded this question poorly. So for you first timers here, this is my second mistake I've made, and this is outside of the norm for me, so I apologize. But I guess to try to clear any muddy points on this, let me just say, which response should the PT expect as a direct result of the beta blockers? So what response would you what response to aerobic exercise would you expect to be typical considering they're taking beta blockers? And if that makes you change your answer, then that's my B. But just know that on your boards exam, if you're a DPT taking your boards exam, there are 50 questions that are ungraded because they are basically vetting those questions to see if they would make good questions in the future. Their heart range doesn't change. I'm not 100% sure what you mean, brother. So beta blockers are going to blunt the heart rate response. Okay, so aerobic exercise, even on people with beta blockers, you would still expect increase. This is why I'm saying it was worded poorly on my part. You measure your patient tiredness with RPE on beta blockers. Yeah, 100%. 100%. You're absolutely right. Beta blockers reduce heart rate. Yes. The reason this is a poorly worded question, and this is my bad, is that you still expect them to increase their oxygen consumption with aerobic exercise, right? You would still expect blood pressure to go up, right? Just as a normal response, but it will blunt the heart rate response. Now, it may not go up equally because if they have a blunted heart rate response, that can impact how much their blood pressure goes up. It was D. Yeah, Nicole. But you still expect these things to be true, right? But if you're taking a person through aerobic conditioning, like let's say you're treating someone post-stroke and they're on beta blockers to help manage their blood pressure, you can't work off of an estimate percentage of their heart rate max or their heart rate reserve because their heart rate response is blunted. And so you have to use the rate of perceived exertion as a better measure. So that's my bad. This was a garbage question, and I will admit that to none of your guys' faces, to my own face, because I can only see my face in the phone. But I apologize for that, guys. That's my B. Oh, this is saying, I remember my reasoning to the question. So increased oxygen consumption, this is talking about VO2 max in particular, and on beta blockers, VO2 max is often reduced, not increased. So I probably could have said something more clear, like increased VO2 max, which obviously would not be true, right? Because if your heart rate can only deliver a certain amount of oxygen at a, because it's blunted, then it's not going to increase your VO2 max, it's going to decrease it. And then I wouldn't expect them to lower your blood pressure. Like, there's not the same blunting of your blood pressure response as there is heart rate with exercise, but it can dampen how high your blood pressure gets with increasing levels of exertion. Number 12, which medication increases the risk of tendon rupture? This is a tricky question. I'm letting you know that beforehand. But this question, oh, I actually think I posted this. Let's see how many of you know. I posted this yesterday. I did. Yes, I did. So, let's see who watched it. I got it wrong. To be honest with you, I'm not sure. Yesterday, I'm not sure that they would put this question on your boards and grade it because two answers are good answers, but one answer is more correct than the other one based on what you know the stem of the question says. But one of these is kind of right under certain conditions. So let me go ahead and just go over it. So the answer, I didn't even tell you, statins, corticosteroids, fluoroquinolone antibiotics, or beta blockers. So beta blockers and statins don't have anything to do, or they don't change the integrity of your tendons whatsoever. The answer is fluoroquinolone antibiotics. It does increase the tendon rupture risk. Now, statins can cause muscle pain and myopathies, but they're not going to cause tendon rupture. And beta blockers have no association with tendons. So corticosteroids, long term, if you're chronically using corticosteroids, it can increase tendon fragility, but fluoroquinolones are more associated. So for instance, I had a patient with myasthenia gravis who had a really bad infection and was on fluoroquinolone antibiotics, and her daughter called me and was like, hey, you need to be careful with her ankles because she's on this medication. And I'm like, right, you're absolutely right. So even being on it for short-term durations can increase the risk of tendon ruptures, particularly your Achilles. I'm putting my hand in front of my mic. Particularly your Achilles. And so corticosteroids in long term can increase the risk of tendon rupture, but that's more with chronic use. Whereas fluoroquinolones are going to be like any duration. Okay. 13. A patient on ACE inhibitors should be monitored most closely for A, orthostatic hypotension, B, hypoglycemia, C, bradycardia, or D, muscle cramping. A patient on ACE inhibitors should be monitored most closely for A, orthostatic hypotension, B, hypoglycemia, C, bradycardia, or D, muscle cramping. You guys take your time. Many of you. Many of you are answering. Let's see. Dang, must be A. Let's go over it. Let's go over it. Okay, so the answer is A because orthostatic hypotension is a common side effect of ACE inhibitors because the common side effect of ACE inhibitors because of what ACE inhibitors are doing, right? They are inhibitors of ACE, which is angiotensin converting enzyme, right? And it's blocking angiotensin 1 from converting to angiotensin 2 because angiotensin 2 increases contractility of the smooth muscle in our arteries. And so ACE inhibitors block that transition of angiotensin 1 to angiotensin 2, which thus decreases our blood pressure, right? But ACE inhibitors don't have the same effect on our heart rate as beta blockers do. Beta blockers do directly hamper the responsiveness of our heart rate with increasing activity, and ACE inhibitors don't, right? So heart rate is usually unaffected with ACE inhibitors. Hypoglycemia, not an ACE inhibitor side effect. Muscle cramping, this is more common with diuretics, right? And diuretics can be used to help manage blood pressure. The reason being is because this is draining you of all of your fluids, right? Which means that a lot of your electrolytes are going to get drained out of you as well. And so if you don't have effective electrolyte balance and fluid balance in your body, then you're more likely to cramp up. So got them confused. No big deal, dude. Thanks, doctor. Yeah, no problem. No problem. We know way too much about medications to get paid as little as we do. And we're not, like, it's not within our scope to do anything about medications anyway. So it's pretty funny. Number 14. A patient taking warfarin presents for PT. Which finding requires immediate referral? A. Mild muscle soreness. B. INR of 2.5. C. Unexplained bruising. Or D. Fatigue after exercise. Read that one more time. A patient taking warfarin presents for PT. Which finding requires immediate referral? A. Mild muscle soreness. B. INR of 2.5. C. Unexplained bruising. Or D. Fatigue after exercise. Hey, Northgate Nightmare and Labs, you just got the number 3 gifter badge, whatever that means. Well, I'm glad to have you, Geo, Life of Geo. How long have you been practicing as a PTA? Or did you just recently get licensed? She took my spot. You just got the number 3 gifter badge. Look at you. Are you guys actually gifting me stuff? Because you don't need to do that if you are. You 100% don't need to do that. But yeah, user, you just took the number 3 spot again. Okay, so let's go over this. I'll tell you how you guys can repay me at the end. Because I actually came up with an idea today, and it's not going to cost anyone any money in order to repay me. I don't want your money because I want you to get out there, start making money so you can pay off those loans. I don't want you to give me that money. I don't want your money. Okay, so the answer is unexplained bruising. Because if they have unexplained bruising, that suggests that they're bleeding, right? They're bleeding somewhere, and they don't know what happened. And it may not be done bleeding yet. Passing the NPTE, yeah, that's a good way you can repay me. What was the INR request? Sorry, I gotta go back. Can you go over INR since PTA? It's not talked about regularly. So what you need to know for this question, what you need to know on this question is INR of 2.5 is therapeutic range, right? And while we're here, let's just go ahead and pull up a table of like INR ranges. We'll just pull up, find a good one. Oh, well, let's just go to the AI, the Google AI overview. So if a person is not anticoagulated, their normal resting INR is going to be between 0.8 and 1.2. Normal results is often found around, hold on, My live is going to end if I don't put this puzzle piece in the right spot. Okay. I also encountered that question before in our PTLE before. So if you're not anticoagulated, it's going to be normal for your INR to be around 1. If you're on warfarin, it's the therapeutic range is between 2 and 3, right? So if a person's on warfarin and they're not between this, that means that they're probably not on a high enough dose of warfarin. It's not our responsibility to manage that. That's going to be the doctor's, but we do need to know what their range is at, because if they're above 3, then they might be too effectively coagulated, and then we have to be really worried about them falling or bumping their walker while we're ambulating with them in the hospital, or them bumping their elbow or sitting too hard on their bed and bruising their butt. Critically high value, above a 5, that's a very high risk of bleeding. I would not mobilize a patient with a 5 INR. And then a mechanical heart valve. This is something that I don't even know that we really need to know, but mechanical heart valve, the INR therapeutic range is 2.5 to 3.5. So there you go for that. But because this INR is 2.5, that's therapeutic range, so that's perfectly fine. And the fatigue is non-specific, not really specific at all to INR. Good luck, you got this. Yeah, Austin, for real. Good luck on your test on Wednesday. I'll be thinking about you, and hopefully, if you're okay with it, I'll probably do it anyway, but I hope it doesn't offend you that I'll probably send up a prayer between now and Wednesday, just to keep in my thoughts, because it's a big test, man. Biggest test of your life so far. Number 15, long-term corticosteroid use most increases the risk of, we just went over this earlier, hyperkalemia, B, osteoporosis, C, hypoglycemia, or D, bradycardia. Let you guys submit your answers. All right. Looks like many of you, the answers are slowing down, so we will go back and look at it. Steroids lead to bone demineralization. Corticosteroids are injecting cortisol into your blood system because it has anti-inflammatory effects, right? But we also talked about, so one of the reasons that a side effect of having corticosteroids in your system is increased resting heart rate, increased resting blood pressure. Some people have a hard time sleeping after they get corticosteroid injections because it increases the response of your sympathetic nervous system, so it can make it harder. What are sides of symptoms? Hyperkalemia is potassium. What are SLS? OD this. User, is this Moans Grown Stones and Bones? Yeah, I guess. That's funny. What are signs and symptoms of hyperkalemia? So if you have too much potassium in your system, that can lead to cardiac arrhythmias, brittle bones. That's super funny. He's recording so you can watch later. Yeah, I am, Red. Let me get back to the answer. So increased cortisol increases the response of your sympathetic nervous system. Your sympathetic nervous system is trying to harvest as much as possible, including glucose and calcium from your bones, to try to, because your brain is assuming that you're in an emergency situation, and so it's either going to try to help you to where you can stand and fight, or you can run away and get away from whatever's causing the issue. So in the same way that Cushing's disease with excessive cortisol can lead to bone demineralization, so can prolonged use of corticosteroids. Steroids can cause hypokalemia for the same reason. It's trying to get, I feel like my lighting just went down. It's trying to get more nutrients for your muscles to be able to utilize. We know that our muscles utilize potassium a lot for muscular contraction. Hypoglycemia, steroids raise glucose for the exact same reason. It's trying to introduce glucose into the blood so your body can metabolize it faster for the energy that you need to either fight the bear or run away from the bear. And then bradycardia is not going to happen on steroids. Signs and symptoms of hyperkalemia. Let's take a look. Signs of hyperkalemia. Lots of weakness, fatigue, tingling, numbness, nausea, vomiting, shortness of breath, and chest pain. Can lead to dangerous heart rhythm issues. Boom, I still got it. Or even sudden collapse or cardiac arrest. Which medication, number 16, let's move on. Which medication class is commonly prescribed for neuropathic pain? A, NSAIDs, B, diuretics, C, beta blockers, or D, antidepressants? Let me read that one more time. Which medication class is commonly prescribed for neuropathic pain? A, NSAIDs, B, diuretics, C, beta blockers, or D, antidepressants? Ooh, this is hard, he says. Good. I wanted to write some harder questions this week. Would you guys take some time to answer? Okay. Answers are slowing down, so we're going to go. The answer is antidepressants. So tricyclic antidepressants and selective norepinephrine reuptake inhibitors often are used for neuropathic pain. I don't know the mechanism of action right off the top of my head for this, but I do know this is true. NSAIDs have poor, not poof, poor efficacy for neuropathic pain, and it's usually because neuropathic pain isn't directly related to inflammation of the nerves themselves. So that's why NSAIDs are not effective for neuropathic pain. Diuretics aren't indicated to treat any kind of pain, and beta blockers don't have any role in analgesia. If this had said gabapentin, I see that all the freaking time in my neuro patients. Ton of them are on pregabalin or gabapentin. Again, I don't remember what the mechanism of action is for the TCAs and SNRIs, so hopefully that's not a question, but we don't have to know that either, right, for our scope of practice. Just an extra thing if you do know. Number 17, a patient taking diuretics is most at risk for A, hypervolemia, B, electrolyte imbalance, C, bradycardia, or D, hyperglycemia. Good. Plenty of you are answering. I'll give you guys a little bit more time because I think, yeah, hypervolemia. Yeah, okay. So let's just go over the answer choices and I'll explain hypervolemia here in a second. So electrolyte imbalance, right? Because diuretics alter sodium and potassium. In particular, our body is always trying to stay in equilibrium with the amount of fluid that we have and the amount of salts that we have in our body. Sodium and potassium tend to come in the forms of salt, sodium chloride and potassium chloride, right? And so diuretics are draining us of the fluid in our bodies, and so in order to keep that balance or that equilibrium in our system, we're also going to be drained of our electrolytes, which means we're going to be led to have an imbalance of our electrolytes, typically low electrolytes, because our body is trying to keep itself in an equilibrium between how much water it's holding onto and how much electrolytes it's holding onto. And so hypervolemia, diuretics decrease fluid volume. So hypervolemia is excessive volume of fluid. And so if we were not on diuretics, we were taking in a ton of salts, or we were just drinking a ton of water, I would expect us to be hypervolemic. Um, Hypovolemia, you probably have heard this in like hypovolemic shock, usually happening when someone is bleeding internally or just bleeding externally, but just like losing a lot of blood, the volume of their blood is decreasing. So increased sodium, no, high, yeah, potentially, but it doesn't just have to be increased sodium. It could just be like your body holds on to more. Okay, so I'm confusing myself. Usually you're going to see increased sodium, increased calcium, increased potassium. With hypervolemia, sodium stands out in my mind as most predominant, but it could also be that you're taking in a ton of water, and so your body is holding on to more sodium as a result of you taking in a ton of water as well. So, yeah, if they're hypervolemic, they usually have more sodium in their blood as well. Bradycardia is not typical with diuretics, and hyperglycemia is not a primary effect of diuretics either. Number 18. Which medication would most likely cause exercise intolerance due to muscle pain? A. Statins, B. ACE inhibitors, C. Insulin, or D. Anticoagulants? Oh, user, you just got the number 2 gifter badge. I honestly don't even know what that means. I made 1 penny off of a live one time. So that was pretty dope. I don't know how I'm supposed to get that penny since the Fed has stopped printing pennies. Okay, let's go over it. Answers are slowing down. Statins. Common side effect of statins are myopathy and muscle pains. So if your patients are on statins, just know if they're complaining of a lot of muscle pain, we may need to refer them, like maybe if they have something secondary that you're suspicious is also going on, then, oh, my lights did go out, I just realized. Then maybe you continue to work with them. But if they're just generally complaining of muscular pain, you might need to have them talk to their doctor, refer them back to their doctor to talk about the statin that they're on, if they're on a statin, and seeing if there is an alternative to treating their cholesterol to see if taking them off the statin will also improve their muscle pain. So ACE inhibitors don't, they can cause cough. In particular, lisinopril is super common to side effects being dry cough, but not myopathies. Insulin does not cause muscle pain, and anticoagulants don't cause myopathies. They cause, potentially, bleeding risk. Number 19, a patient with asthma uses a short-acting bronchodilator. When is the best time to use it before exercise? A, immediately after exercise. B, 30 to 60 minutes before exercise. C, 10 to 15 minutes before exercise. Or D, only if symptoms occur. Uh-oh. Luis is jumping up in the gifter badge. And when I'm back in Chicago, I feel it. Okay, you guys are still answering. Give you some time. This is a tricky question, too. Hey, I saw you join my live for like 5 seconds. Did you like what you heard? Okay, let's go over this. Okay. So the answer is C, 10 to 15 minutes before exercise. This is the optimal bronchodilation window. So it is common in terms of how we have seen things prescribed. This is an example of like the difference between what you may have seen clinically versus what is textbook. Okay, so the textbook would say 10 to 15 minutes before exercise because D, the response that I gave is just saying if we use it prophylactically, it's going to reduce exercise-induced bronchospasm, which like a rescue inhaler or like using, oh my gosh, what is the name of the medication? I used to have to take it. I don't know. I can't think of it right now, but you guys probably know what I'm talking about. Albuterol. Um, it can take some time to get peak effect. And so if you want it to have peak effect and hit that optimal window, albuterol, yep, you should have your patients take this 10 to 15 minutes before exercise, right? It can still be useful as a rescue inhaler, but this is, again, an example of what we have seen clinically versus what the textbook says. And so textbook would say 10 to 15 minutes before exercise optimal bronchodilation window. However, I will say, in the real world, most of the time, if anyone's asking me how to take their inhalers, I say, well, what did your doctor say? You should take it how your doctor prescribed it, because I am not the one that's allowed, based on my license, to give advice on how to take medications. In fact, I could probably get sued for that, so I never do it. I don't even talk to people about supplements. I don't talk to them. I mean, I tell them that if they're at risk, like if they're getting older, then they should talk to their doctors about getting on vitamin D or calcium to help protect their bones and their muscles. But I do not tell them to start taking vitamin D because not my practice. Number 20, last one. Did this make plenty of sense? I didn't get any pushback from any of you guys, and so sometimes I'm like, either I made a ton of sense, number one, number two, your brains are getting tired, or number three, you guys think I'm full of crap. So if you have pushback, don't be afraid to tell me. I'd be happy to talk with you about it, and there are times where I'm wrong, like the time that I wrote poof instead of poor, or the time I wrote hypertension instead of hypotension. Which medication increases fall risk due to sedation? A. Antihypertensives. B. Insulin. C. Statins. Or D. Benzodiazepines. Let you guys answer. Scroll too far. Shh. You didn't see that, Riley. Prophylactic does not mean rescue, Gemma. What it means is using it as a preventative measure. So like rescue inhaler, you're using it because bronchospasm is happening right now, whereas prophylactic use of the inhaler would be to use it before you have bronchospasm so that you don't have bronchospasm. So that would be prophylactic use. Samir, I would talk to. I'm not an academic. I'm not a faculty. I'm adjunct faculty, but I teach not cardiopulm and not pharmacology. So I would talk to your teachers about what they have seen textbook-wise in terms of what they would expect the NPTE to ask you. And if they say something different, then listen to them more than me because they've been teaching people to take the NPTE for much longer than I have. So that's what I would recommend. Benzos make you loopy. And if anyone saw the answer, but also I know benzos is almost like being drunk. Well, and if you guys have seen the latest season of Stranger Things, Robin stole benzos to drug that family, right? So they could kidnap them. So benzos sedate you. Did anyone watch? Tell me I'm not the only one that watched Stranger Things. I've got some hot takes on it. I don't know how many of you liked it versus didn't like it, but I've got some hot takes. Benzos, sedation's a common side effect, increases your fall risk. Antihypertensives, they cause hypotension, not sedation. So hypotension can be a fall risk, or it can lead to increased fall risk, but this is asking specifically increases fall risk due to sedation, right? So antihypertensives might increase a person's fall risk because of hypotension or postural hypotension, not because of sedation. Insulin is going to increase the risk of hypoglycemia, which again could cause someone to be at an increased risk of falls if they're having a hypoglycemic event. No time to watch Stranger Things in full study mode for NPTE in 3 days. Skyler. Don't worry, girl. You'll catch up after you pass your test. Statins, muscle-related side effects, not sedation. So all of these could increase fall risk, but only one of them is increasing fall risk because of sedation, and that's benzos. Okay. So now, let me tell you how you guys can repay me if you want to do this. You don't owe me any money. I'm never going to ask you guys for money. What I want, ultimately, if you guys enjoy my content and you feel like I am helpful, if you feel like your classmates or your friends would benefit from this kind of material, then share my lives with them, share my TikTok name or my YouTube account so they can rewatch lives. But really, what I want, because this would make me feel a little bit nicer, better, um, is when you guys pass your tests, and I'm saying when you pass your tests, I don't deserve any of that credit because you guys are the ones putting in the work right now. You guys are the ones preparing to take the test. I've already done that. I only owe my test to me because I'm the one that put in all the work. You guys are the ones that are putting in all the work, so I don't deserve any credit for you guys passing your boards. Okay? What I would like is a nice, well thought out email or letter to tell me about how you guys plan on or intend on improving uh, the career or the job field. So this is me getting on my soapbox for a bit. Many people, myself included, complain about the state of physical therapy in terms of accessibility to patients, in terms of cost of education, in terms of pay when we get out, in terms of what we are actually allowed to do versus what we're trained to do. A lot of states feel like that PTs aren't practicing up to their full potential when it comes to what we are trained for. I completely agree with that. And so I have pissed and moaned about lots of different things in terms of how PTs are being held back and the things that are holding us back that we are putting on ourselves, like the crazy cost of education versus what we actually get paid when we get out. And so currently, I am running for the APTA House of Delegates for my state. And so if I win, I'm going to be in a runoff against one other person because I tied in the original vote. So if I win, then basically I will represent my state, which is Arkansas's interest at the greater APTA House of Delegates, which meets on a national level. So it's sort of like senators or Congress people meeting for like a session of Congress, basically. But it means nothing if what we want to do is to become PTs so we can make a lot of money, so we can burn and churn through patients in a PT mill, just so we can make some more money for a company that doesn't care that much about us, right? So what I would like, technically we are on the way to becoming PCPs. Well, it happened in Utah, so I'm hoping that things will keep getting pushed in the right direction, but it takes the work of dedicated people that want to see changes made to help impact the state of healthcare in the country, right? We know what effect physical activity can have on people and how it can actually prevent the development of chronic conditions. And we are living in a time where chronic conditions are running rampant in our population, especially the older and older we're living to. And so we need to be working more on preventive care rather than reactive care, proactive care, if you will. And so if you guys want, when you pass your tests, I would like it, just be nice for me to read through, of what you guys plan to do with your license in terms of advancing physical therapy during your career. And so if you want to do that, you can direct message me and ask me for my email or my home address. You can send me an email or you can send me a letter. And that's all I want. I don't want your money. I just want to know how you guys are going to be the next generation of physical therapists and physical therapy assistants that propel the profession in a direction that it needs to be going in. And that's all I want. That's all I ask. You guys don't have to do that. If I never get any letters, I'm not going to cry. I just thought that would be cool. If you guys want to repay me, if you feel like I'm helping you, greatest clinical director ever. Shut up, Cooper. Cooper was, I don't know if I'm allowed to say that. Is that a FERPA violation, Coop? Cooper was a student of mine. I was his CI. And so, yeah, that's what I would want. I don't really have anything else unless you guys have particular questions for me right now. But I don't have anything else for you guys tonight. Feel free, if you guys are taking practice tests, I'll open this up to you guys again. If you guys are taking practice tests and you want some pointers on how to direct your studying, feel free to share your test results with me, your practice test results with me. You can either send me a message on TikTok once I accept the message, you can just send me screenshots. I've done that for a few people just to try to help guide studying in the next couple of weeks in between taking tests. That's always an open invitation. If you guys want me to look over your test results and talk with you about how I would direct my studying if I had gotten those test results, then that's fine. And I'm more than happy to do that. I usually get back to those people in just a couple of days. I did forget one person for a couple of days and he had to reach back out to me. So I'm sorry. But yeah, that's open invitation if you guys ever want to do that. Are you older? Are your older lives on YouTube? Yes, they are. My YouTube link is on my TikTok profile. So you should be able to click on that and it'll take you right to my page. I will get this one posted by the end of day tomorrow. So, all right, guys. Can we do that with the Pete's too? 100%, Gemma. Yep. If you want me to take a look at your scores and help direct what I think you ought to do to get the best bang for your buck in terms of studying based on content areas, and then also pointers on how to time yourself or plan your practice tests. So that way, if you're like hitting test fatigue in sections 3 and 4, how to try to overcome that test fatigue, I'd be happy to talk with you guys about that too. All right, guys, I'll see you next week. Next week, we're going to go over non-systems, gate analysis, and deviations, and I might pick one other thing just because I don't know. I'll be able to supply 20 questions just on, I mean, non-systems probably. I'll try to make them more research-based since that's always a crappy area. No one likes research except for the nerds. I'm just kidding. That's a joke between me and a colleague. But all right, guys, you have a great week, and I'll see you next Sunday. Bye.